This is the continuation for prostate cancer part 5. Uh, Screening PSA and subsequent risk of dying from prostate cancer. Mean age of 40 to 50 for men without risk factors for prostate cancer. Example, no family history, not African ancestors, no genetic predisposition. Some physicians think that using PSA to predict future risk is marginal value because it does not confer a clinical advantage over testing starting at age of 50. Nonetheless, PSA can predict future risk in this age group. A PSA less than or equal 1 at age of 45 to 49, this man has the lowest risk of dying from prostate cancer. A PSA is 1.6 at age of 45 to 49. This men have nine-fold higher risk for dying from prostate cancer within 25 years compared to men with PSA less than or equal 1. So those who have less than or equal 1 have a lowest risk of dying from prostate cancer. Those who have PSA of 1.6 at the age of 45 to 49 have a nine-fold higher risk of dying from prostate cancer within 25 years compared to men with PSA less than or equal 1. Men age 60 with men with PSA less than or equal 1 at the age of 60 have a very low risk of developing prostate metastasis, 0.5%, or dying from prostate cancer, 0.2% by age of 85. Men at men age 70 to 25, PSA less than 3 at age of 70 to 75. These men have very low risk of dying from prostate cancer, that's less than 3%. PSA 3 at age of 70 to 75, these men have a 7% risk of dying from prostate cancer, but the risk increases as they get older. So the PSA 3 at this age group, it is 7% risk of dying from prostate cancer. PSA elevation typically occur 6 to 13 years before prostate cancer cause symptoms. A 2018 guideline for prostate cancer screening. If screening is offered, physicians should discuss the benefit, risk, and limitation of prostate cancer screening with patients and then offer testing. The decision to screen should be a shared decision between the patient and the physician. Screening consists of PSA with or without digital rectal examination. Who should screen? Men with life expectancy 10 to 15 years, routine screening is not recommended. Men with life expectancy 10 to 15 years, age 40, the AUA recommend gains screening in these men because they have very low risk of prostate cancer. Age of 40 to 54, routine screening is not recommended for men with average risk of prostate cancer. Consider screening in men at high risk, such as men with African ancestors, or family history of lethal adenocarcinoma such as prostate, ovary, pancreas, male or female breast cancer. Age of 55 to 69, offer screening through shared decision making. Age 70, routine screening is not recommended but may be reasonable in men who are in excellent health, minimal comorbidities, and who have life expectancy more than 10 years, especially if they have a family history of longevity. A screening interval of 2 to more or more years may be preferred over screening every year. A screening interval can be individualized according to baseline PSA. For example, men age 60 with PSA less than 1, the risk of subsequent dying from prostate cancer was only 0.2%. Therefore, this men may benefit from less frequent screening. The U.S. Preventive Service Task Force, that's USPSTF 2018 guideline, that's the U.S. Preventive Service Task Force, suggests the clinician can offer or provide PSA testing for selected patients depending on clinical circumstances. and that there is at least moderate certainty that benefit is a small grade C recommendation. The US BSTF discourage the use of PSA in men age more than 70 grade D recommendation. Example screening protocol. Guidelines on prostate cancer screening are highly variable. We show it in the tables. The reader is encouraged to read the guidelines that are relevant to the country in which you practice in order to account for the variation in guideline recommendation. An example screening protocol was synthesized from multiple guidelines. This is a comparison screening recommendation for prostate cancer. This is a guideline, and this is the age started screening men with life expectancy more than 10 years based on the prostate cancer, average risk, high risk, very high risk. And this is the age to stop screening and suggested screening test. As you see here, the AUA and NCCN and ACS, those three guidelines, AUA 2018 and NCCN 2021 and ACS to 2021, those doing the digital BSA with digital rectal with or without digital rectal examination, and the age group is value 55. This is for average risk, 45 for average risk, and also 50 for ACS average risk. And age group AUA 40 to 54. This is high risk and very high risk. And age to stop screening is 70, but individualized is an option. Individualized in these three studies, AUA and NCCN and ACS 2021. And the age group here is 45 to 40. Here it's only in NCCN high risk and very high risk 40. So 45 to 40. This is 45, this high risk, and 40, this is a very high risk. So this we consider to do BSA and with or without digital rectal examination, and age to stop screening is individualized. Okay, so this is the AUA, 55 average risk, and this is 40 to 54, high risk and very high risk. And here NCCN 2021, 45, this is average risk, high risk and very high risk 40. And ACS 2021, the age is average risk age for them, it's 50, and 45 for high risk and 40 for very high risk. CUA 2017, 50 for average risk, this is the age, and 45 for high risk and very high risk. We'll do only BSA, and thus we will stop 60 if the BSA less than 1, all other at 70. This is the CUA. EAU 2021, the average risk, the age to start screening for men who have life expectancy more than 10 years. That's for men more than or equal 50. High risk, we can do it at the age of 45, and very high risk for age of more than 40 or more than 40. BSA and digital rectal examination together. So we will stop the age to stop less than 15 years of life expectancy. The BCFA 2016, age of 50, so to start for average risk, high risk 45 and very high risk 40, not specified to stop only BSA as well as in the US BSTF 2018, they mentioned to do BSA only and stop at the age of 17, stop screening with BSA, and the age start at the age of 55 for all group. That's average risk, high risk, very high risk. The BSA for prostate cancer screening, BSA is not capable for diagnosing prostate cancer. BSA only estimates the risk of prostate cancer. The higher the BSA, the higher the risk of prostate cancer. Cancer can be present even when the BSA is very low. Therefore, the term normal should probably not be utilized for PSA. The term low risk or lower risk may be more appropriate. Cancers detected by PSA are more likely to be organ confined and less likely to be metastatic. Therefore, screening with PSA detected prostate cancer at early stage. PSA elevation typically occurs 6 to 13 years before prostate cancer causes symptoms. The decision to perform a biopsy is often based on many criteria, not just the total PSA value. A single abnormal PSA should not prompt prostate biopsy. The abnormal PSA level should be verified after a few weeks using the same assay at the same lab. Minimizing confounding causes of elevation PSA such as genitourinary infection, ejaculation, and prostate trauma. Example, urethral instrumentation, prostate massage, cycling, motorcycle riding, long plane and long car rides, etc. Also, approximately 10% to 30% of elevated PSA tests will decline to normal value within the following years. However, PSA returning to the normal does not eliminate the possibility of prostate cancer, so this means should be monitored closely. In asymptomatic men, attempting to reduce the PSA with a course of antibiotic is not recommended. Using antibiotic in this setting does not appear to alter the PSA. Hemodialysis and peritoneal dialysis do not alter total PSA significantly. Abnormal total PSA value, there is no universally accepted threshold value above which the total PSA is considered abnormal. Higher PSA thresholds reduce unnecessary biopsy but increase the risk of missing cancer. Lower PSA threshold reduce the risk of missing cancer but increase the detection of clinically insignificant cancer. Age and ethnicity specific reference range. This may help account for variation in the risk of prostate cancer between the different populations. This is the age and the normal serum range of PSA. If the age of 40 to 49, the Caucasian, that's it's 0 to 2.5, African American, it is 0 to 2, Asian American 0 to 2, and 55 to 50 to 59, 0 to 3.5, this is Caucasian, and African American 0 to 4.5, and Asian American, the normal serum PSA is 0 to 4, and 60 to 69, 0 to 4.5, this is Caucasian, 0 to 4.5, this is African American, 0 to 4, this is Asian American, and 70 to 79, 0 to 6.5 Caucasian, and 0 to 5.5 African American, 0 to 5 Asian American. This is the normal serum PSA. It is important to realize that the PSA reference numbers used in most screening and diagnostic algorithms are based on men not taking a 5-alpha reductase inhibitor. 5-alpha reductase inhibitor finasteride typically reduce the total PSA by approximately 50% within 12 months. So after 12 months of treatment, the clinician can double full PSA to estimate what the PSA would be in the absence of 5-alpha reductase inhibitor in order to compare it to reference PSA value. Abnormal change in the total PSA in men taking 5-alpha reductase inhibitor. This medication reduce the total PSA by approximately 50% after 6 to 12 months of treatment. Also, the maximum PSA reduction and the time to reach it are highly variable. Men whose total PSA does not decline by 50% with 12 months of starting 5-alpha reductase inhibitor, or whose PSA rise while on 5-alpha reductase inhibitor have higher risk of prostate cancer. Therefore, prostate cancer is often recommended in this. Prostate biopsy is often recommended in this men. Using 5-alpha reductase inhibitor appear to improve the ability of PSA to predict the presence of prostate cancer, particularly high-grade cancer. 5-alpha reductase inhibitor usually do not alert the percent of free PSA. So in men not taking 5-alpha reductase inhibitor, this mean PSA velocity may help to determine the risk of prostate cancer. Also, the evidence is conflicting as to whether the PSA velocity is useful for predicting the presence of prostate cancer. For total PSA less than 4 nanogram, PSA velocity is 0.35, more than 0.35 nanogram per year suggests the presence of the clinically significant prostate cancer. So increasing the PSA, the PSA velocity more than 0.35 in men with PSA total BSA less than 4. So this is increase the presence of the clinically significant prostate cancer. Men with BSA velocity more than 0.35 and BSA less than 4 have a higher risk of dying from prostate cancer 5 to 15 years later. For total BSA 4 to 10 nanogram per ml, BSA velocity 0.75 nanogram per ml per year suggests the presence of prostate cancer. For total BSA more than 10, BSA velocity is not useful. BSA V require at least 3 BSA level taken at least 6 months apart. This is the BSA equation that the BSA second BSA per nanogram minus first BSA per time, that the time here from BSA first BSA or the time of the first BSA plus BSA third BSA minus second BSA per time year of BSA to 2 years of BSA third BSA. This is the BSA velocity. This is the end of prostate cancer